Hello and welcome to our continued lecture on chapter 26. In this video, we are going to discuss heart failure, and that is going to be when the heart is unable to generate adequate cardiac output in order to meet the metabolic demands of our tissues and our organs. And this can include cardiac decompensation, cardiac insufficiency, and ventricular failure. All that is done through inadequate perfusion of our tissues, increased diastolic filling pressure of our left ventricle, and pulmonary capillary pressures increasing. And a few of the clinical manifestations are illustrated here, although we're going to go into a bit more detail. And I wanted to include this FACES mnemonic for 5 warning signs of heart failure, which include F for fatigue, A for activity limitation, C for congestion, E for edema or ankle swelling, and S for shortness of breath. And I also included this figure over here, which gives you a nice summary of right heart failure versus left heart failure. So feel free to reference back to this, but we will go through each side one by one. So starting with the left heart failure, and we can categorize heart failure into these 2 types. We have what's called reduced ejection fraction, which is also known as systolic heart failure. And this means that ejection fraction is less than 40%. Our heart has the inability to generate adequate cardiac output in order to perfuse our tissues. And the stroke volume is going to be influenced by these 3 major determinants: contractility, preload, which if you remember is going to be the volume of blood in the ventricles at the end of diastole, and then afterload is our last determinant. And that, if you remember, is going to be the resistance that the left ventricle has to overcome in order to move the blood into the aorta and to the rest of the body. So through these determinants, we get disruptions that decrease cardiac output, and that falling cardiac output is going to progressively worsen into heart failure. So we'll start with contractility. This is typically reduced by diseases that disrupt the myocyte activity. And the most common cause of this is going to be a heart attack, a myocardial infarction. That contractility is decreased due to that. And then our stroke volume is going to fall, and the left ventricular end diastolic volume, also known as our preload, is going to increase. This then is going to cause a dilation, which we see pictured over here, of our heart, and that can increase the preload. And at first, this increase in preload is actually improving the cardiac output, but it can only do it for so long, and then that preload continues to rise. We start to get more dilation of our heart, and this leads to dysfunction of our sarcomeres, and it decreases the contractility further. With decreased contractility even further, we are going to have less blood that then leaves the heart, and we can start to also see increased afterload. This is a increase usually due to pulmonary vascular resistance, which if we have resistance in here, that means even more blood is basically staying within the left ventricle. So with our decreased cardiac output, we're going to get these clinical manifestations of dyspnea, or which worsens into orthopnea, a cough of a frothy sputum, fatigue, decreased urine output, and edema. We can get pulmonary edema, hypotension or hypertension, and an S3 gallop, which is a third heart sound that is going to be a brief vibration early on in diastole. Now, the other type of left heart failure is going to be our heart failure with preserved ejection function, or diastolic heart failure. And in this, we see pulmonary congestion takes place despite having a normal stroke volume and cardiac output. And the major causes of this will be hypertension-induced myocardial hypertrophy and myocardial ischemia induced ventricular remodeling. So what we mean by that ventricular remodeling is that there's some type of disruption of the normal myocardial extracellular structure, and it causes progressive myocyte contractile dysfunction over time. So with that, we have decreased compliance of the left ventricle and abnormal diastolic relaxation. And this is due to that decreased ability of our monocytes to actively pump calcium from the cytosol, which causes the impaired relaxation. So our ventricular lumen is now smaller during diastole, and so we get a built up of blood volume here and increased preload as a result. And then that pressure is going to be reflected back into pulmonary circulation because our pulmonary veins are back over here, and that leads to pulmonary edema, pulmonary hypertension, and right ventricular hypertrophy, because now we've got resistance. So the right ventricle has to work harder to push that blood out into pulmonary circulation. So our manifestations could be dyspnea on exertion, fatigue, and like we said, the pulmonary edema that could develop over time, and an S4 gallop, which is also known as a atrial gallop, and it's going to be from the contraction of the atria trying to push that blood into a stiff hypertrophic ventricle. So I really like this slide here because it really summarizes left-sided heart failure. From the left side, we get venous return back into our lungs, and we get pulmonary congestion and pressure. And because we have this fluid buildup within our lungs, that is what is going to make gas exchange really hard and cause dyspnea and orthopnea, which makes breathing especially difficult when they lay down because that venous blood flows more easily from the legs to the heart and into the pulmonary circulation. So if you were to listen to the lungs, you may hear some crackles or rails while breathing. These patients also seem to gain weight because the body is really holding on to the fluid. Even the urine production is going to decrease because your body is trying to hang on to all the fluid that it can. And since all of this fluid is going back into the lungs, we are not getting sufficient blood being sent through the aorta and to the rest of the body. So we're not supplying the body organs, and we have a failure that then leads to low organ perfusion and hypoxia. Next, let's discuss right heart failure, and this is our inability of the right ventricle to provide adequate blood flow at a normal venous pressure. And it could result from an increase in the left ventricular filling pressure that is reflected back into the pulmonary circulation. And it's most commonly caused by a diffuse hypoxic pulmonary disease. And we could see this illustrated on the right-hand side over here. When we have that lung disease taking place, we're not getting adequate oxygen supply, and also we're getting an increase in pulmonary vascular resistance, which then is going to lead to an increase in the force of our right ventricle contracting, and that causes an increase in the right ventricle's oxygen demand because the muscles are working harder. So both of these things are then leading to our right ventricle having hypoxia take place, and it decreases the force of that right ventricle being able to contract without oxygen present. We then will see an increase in the right ventricular end diastolic pressure, which increases the preload, and then eventually increases the right atrium preload, and we get a result of peripheral edema. Now, I really like this illustration here showing that taking place because of that peripheral venous congestion. All of this is going to be backing up into several different organs. Now, when right-sided heart failure is due to a lung disease like we saw in the previous slide, it is called cor pulmonale, where the right side is going to have hypertrophy and essentially fail. And one of the clues to this taking place is that we have the jugular veins becoming distended, in which we have this enlarged vein look here. And again, this is due to that venous congestion from all of this fluid backing up into the veins, whether it's the superior vena cava or inferior vena cava. And that fluid backing up into our organs makes them enlarged. So we are going to see cirrhosis, and we call this cardiac cirrhosis specifically, and that leads to liver failure. We can have fluid spill into the peritoneal spaces in the abdomen and cause it to enlarge, and this is called ascites. And the fluid backing up into our peripheral tissues causes pitting edema within the legs when we're standing and into the sacrum too when we're laying down. Lastly, we have high output failure, and this is essentially a condition where your heart is initially working normally, but your body has an increasing need for more blood, requesting increase in cardiac output, and the body is failing to meet that need. And causes of this could be anemia, beriberi, sepsis, and hyperthyroidism. So let's go through this schematic that your book put together. When we are anemic, we of course know that we don't have the oxygen carrying capacity that our blood should, and so we get impaired oxygen delivery, and we'll kind of talk through this in just a little bit, but let's go through some of the others here. In beriberi, this is a thiamine deficiency, and it's caused due to malnutrition, which is typically secondary to chronic alcoholism. And when we have this deficiency, we are going to see that we have impaired cardiac metabolism, mostly because this thiamine deficiency impairs all types of cellular metabolism in all of our tissues. But here we're seeing an effect in the heart, and that is going to lead to insufficiency within contractile strength, which then is going to decrease cardiac output. So our body is not able to keep up. The other thing that happens is that we are going to have this thiamine deficiency cause peripheral vasodilation, which decreases the systemic vascular resistance that impairs oxygen delivery, just like anemia. The other cause, sepsis, is going to cause systemic vasodilation, which then is going to decrease our systemic vascular resistance, just like in beriberi. And we're also going to get a fever that develops. So we know this pathway here, but with the fever, we can get greater demands from the tissues for oxygen, and that leads to tissue hypoxia, which can cause a release of our catecholamines, increasing our heart rate and stroke volume, and increase in cardiac output. So our body is trying to keep up with the demands with it, but eventually it is going to run out of fuel, let's say. And then lastly, we have hyperthyroidism, which we know when we have an excessive excretion of our thyroid hormones, we are going to get an increase in our basal metabolic rate, which is going to increase the demand of our tissues for oxygen, leading to the same scheme we just talked about. So the strain of these demands for increased output when we have impaired metabolism can deplete our cardiac reserves until we get low output failure that takes place.